it would not be a sufficient challenge for him to ask him to talk about how do we assess disease activity. So we came up with this title, Dimensions of Health, and what are the implications for the management of people with arthritis, which I'm sure he tried his best to meet head on. Piet.
Okay, thank you, George. Kalispera. So we have a change of speed and a change of language, because Kalispera is the only word I know in Greece, and its variations, of course, Kalinichta, Kalimera. So I would like to continue in English. George asked me in January about to give this talk, and he gave me this title of the presentation. And I said to him, you know, that's quite weird, because I have never given a speech about this subject in the last year. So don't leave the room, because I read a lot about it, and I'm trying to incorporate what you have heard in the first presentations tonight in what we are trying to do in daily clinical practice. And in fact, asking me to give a presentation about this subject is the same as asking a Greek to talk about the dikes in the Netherlands. And you know that most of our country is below sea level, so if we wouldn't have the dikes, the Netherlands would look quite different, and about half of the country would be under the water level. Luckily, I'm living in the eastern part of the Netherlands, so I would be near the sea at that time. But, you know, when I was the last time in Greece, that was in a workshop George organized in Athens, this was the journal which was in the room of my hotel. And it's about health in Greece, and there was a lot of advertisements in this journal about the health in Greece currently, but also from the past. And you all know, of course, the important names. And in fact, what we are trying to implement in daily clinical practice nowadays has been invented already 2,500 years ago, right away here in Greece and near this spot where we are now. And if you read the literature, or I read the literature about it, and then you find a lot of statements from that time which are currently, you know, in as well. And so they were talking about a healthy body is a well-balanced body. They talked about self-sufficiency, which is the same as empowerment, which is a term which we are using nowadays. And we also know that it's important to educate the patients if you want to empower the patients, if you want to have good discussions with your patients, and if you want to have shared decision making with your patients, you have to educate the patients. And at that time already, there were special people, sophists called, who went to all the different villages to educate the patients about health. And you know those terms from the physiocratic schools, like the natural causes for diseases, but also the importance of the environment, both the physical environment and also the emotional environment for health, and the influence of human behavior on health. So all those terms already existed at that time, which we are using nowadays again. And in fact, we have lost that idea of health for many, many decades, I think. And we are close to the center where it all started 500-600 years before Christ. So, in fact, what is disappearing is the biomedical model, the old model that the doctor knows it all. And this old model fits with the old definition of health from the WHO from 1948, which stated that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And there are a lot of disadvantages of this old definition of health. So one of the disadvantages is that we are all mostly of us are unhealthy according to that definition. And due to that, you will get the medicalization of society. So you will try to get everybody healthy according to that definition. From that time, from that old definition in 48 until now, there has a change. There has a change in the demography. So there are more elderly people nowadays than in the mid of the last century. And there is also a change in the nature of the diseases. At that time, in the mid of the last century, there were a lot of infectious diseases, acute diseases, and those have been treated well. So now we are facing more chronic diseases, like the musculoskeletal diseases, than in the mid of the last century. So we have to change the definition of health probably as well. So there were many different meetings about new definitions of health. So one of those was the Ottawa Charter Health Promotion in 1986. And they were talking about the biopsychosocial for health and disease, so including the environment, the human behavior, the biological and the psychological and the social dimensions of both positive and negative health. So that was quite already another definition than the old definition of health. And this went further, and in 2011, a new definition of health was given by another group, which stated that health is the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. So this is a more dynamic definition of health. And what important is from this definition that there is more, that it's very important how you communicate this with the patient. Because if the patient has to self-manage and to adapt, you have to communicate that with the patient, what is the status of the patient at that time, and how can you help the patients to manage their disease. So in fact, there is a change from the old paternalistic approach of a doctor to a more modern approach. So the paternalistic approach was traditionally characterized by medical consumption. There was a high physician control. Doctor knows it all. The doctor will tell the patient what to do and how to get better. The doctor is dominant and takes on the role of the parent, and the patient is submissive. While we are changing to the new model with shared decision-making, in which the doctor plays more a coaching role, is more the teacher for the patient. It has a biopsychosocial approach, and there's a patient-centered communication. Of course, the shared decision-making, the degree of sharing, is not the same, it's not a static way of sharing. So I always compare it with a visual analog scale going from 0 to 10 or to 100, in which on one side there is no shared decision-making at all. The doctor decides it alone. And on the other side, the extreme side, is the patient decides it alone. And you have everything in between. And it depends both from the patient as well as from the situation the patient is in, whether you will have a more paternalistic role or you will have a more shared disease-making process. Of course, for instance, if you are in an acute, life-dangerous situation, you will have a paternalistic role because you will not ask the patient, what should I do, or what do you think about this or that, if the patient is in a life-stressing procedure. And here you have 5 different models, this going from one side in which the patient stated that I prefer to make the final selection about which treatment I will receive if the patient is fully in control and self-managed and is deciding themselves. To the other side, on the right side, I prefer to leave all decisions regarding my treatment to my doctor. And you have all those situations in between. If we go to rheumatoid arthritis, for instance, as an example for musculoskeletal diseases, we do know it's a chronic disease. It has implications, of course, for the physical component, but has many other implications as well. And I think there were several talks this morning or this afternoon about it, about the social and psychological component. And it affects more than the joints as well. It's an inflammatory process which has different aspects of the body. It's a systemic inflammatory disease. It will lead to disability and a shorter life expectancy, but also more work disability, fatigue, and a lower quality of life. In fact, what we are doing and did is that we do know that disease activity has an influence on function of the patient and on radiographic damage. And the red arrow is there because our medications are all focusing on disease activity, and by suppressing disease activity, we know that we preserve function and that we prevent the occurrence of radiographic damage. But there is more than that. We also know that radiographic damage is, for instance, also influenced by osteoarthritis, and that disability is also influenced by age, comorbidities, gender, and disease duration. So the picture of disease activity, disability, and radiographic damage is only telling part of the total story. This was shown earlier this evening by when we were doing research for how to assess disease activity in patients with rheumatoid arthritis. And we did that because we were trying to find individual criteria, response criteria, to find, for instance, predictive factors for response, but later on also for monitoring disease activity. But there is more than disease activity in patients with rheumatoid arthritis. And this is a figure also from one of the publications of the New Health model from Huber, which you can use as a way to communicate with your patients about the different ways rheumatoid arthritis has impact on the patients. So you could ask your patients, for instance, to fill in this diagram at home before they are visiting you at the outpatient clinic. If you look how this new impact of health on patients with rheumatoid arthritis is being followed by the patient and how it's being seen differently by the physician and the different healthcare professionals. And the patient is depicted in this figure. In purple, the middle line is the line of the patients. And the patients, they feel that the different aspects of health, which are depicted on the bottom line, so bodily function, mental, social, spiritual, etc., are more or less equally contributing to health in the patients, while the physicians think, for instance, that the spiritual dimension or the social participation are less important for patients with, contributing to their health. So there is a difference in the way health professionals and patients look at health and the importance of the different aspects. And in fact, we did the same in patients with rheumatoid arthritis. So we had a questionnaire, an identical questionnaire, which we asked 230 rheumatoid arthritis patients and more than 100 rheumatologists. And we gave them different questions with different combination of items. And one of the questions was, what is the most important thing to decide whether you should change your disease-modifying antirheumatic drug? And the results was, and you don't need to read this, but in the top part, all the reasons for the rheumatologist to change a treatment. And here you see that it is more the physical components of health. So it's the swollen joints, the DAS28, erosions, impression of disease activity. Change of disease activity are important for rheumatologists to change the medication. However, for patients, it was on the bottom. For the patients, it was more the function, the trust in the rheumatologist, motivation, satisfaction with the current medication, expressing concerns. So there were different reasons for patients and for physicians to change the medication. And you can imagine that if you don't communicate well with your patients what the reason is for you to decide to change the therapy, that the patient will not follow your advice. If the patient is being satisfied at that time point with the medication, but you are not because you have still investigated, assessed several, for instance, swollen joints in that patient, and you do know that at time, in 5 years or 10 years, that will lead to destruction of the joints, you would like to change the therapy. If you don't communicate that is the reason for you to change the therapy for the patient, then the patient will probably not really follow your advice. So it's important really to correctly communicate with your patients. Is it possible to have a shared decision-making and a self-management in our patients with rheumatoid arthritis? And this is showing you that in our outpatient clinic, we have about 800 rheumatoid arthritis patients. We do have a web-based system in which patients can enter the system from at home, filling in questionnaires, and also see how the disease activity is, how the medication is, etc. 400 out of our 800 patients do have an internet account. About 200 of those 400 are actively filling in questionnaires. And about 50 patients, so it's about 6% of the total population, is doing self-monitoring. So they are regularly filling in questionnaires, they are regularly monitoring their own disease activity. So it's a very small proportion of the patients who are able to do self-monitoring in daily clinical practice. So in order to increase that, we do need to educate our patients more carefully. And what is needed? This was a questionnaire in the New England Journal of Medicine, the Catalyst, in which showing that time is a very important part. So the time in our outpatient clinic spending with the patient is the most important part of having more patients involved in the shared decision-making. And you see at the bottom, the tool is less important. Often we think that the tool is the most important part for the shared decision-making. While in this interview you do see that is the least one. More important is to have attention for it and time for it. In the shared decision-making model, it's self-management important, that patient, and that's also in the definition, the new definition of health, that the patient should self-manage their disease. And we could help those patients with some instruments to assess several things like mobility, for instance, also disease activity. And what are the advantages of those self-management procedures? That patients are more involved in their treatment. They are empowered. It could also be time efficient and cost effective. They have the possibility to check the information of the medical record, and they can correct the medical record and say to us, okay, doctor, I see in my system that you think that my medication is such and so, but it has changed, so you have to change that in the system as well. There is a possibility of off-site home monitoring, and it's also possible to increase the frequency of monitoring. Often we do see the patient every 3 months or every 6 months, and we don't know really what happens in between. If the patient is doing self-monitoring, we can get that information for free. What can we measure with self-management is disease activity. There are several questionnaires to assess the disease activity, but also medication checks, comorbidity checks, and simple measurements with wearables like activities and steps can be measured. If you take self-management with a questionnaire or with a visual analog scale, you could set a target for the patient. So you could say, okay, we are measuring disease activity with a patient-reported outcome in a certain patient, And then you do see that the disease activity is suppressed, there is improvement, and at some time point you will reach a stable state of disease activity, and then you can discuss with your patient what would be the target, and also the target, the alert threshold for which the patient needs to, to ask you for consultation or come to the outpatient clinic. And if you follow that patient, you can set the tool in such a way that if you have an increase of your disease activity measured with the patient-reported outcome over the threshold, there could be an alert to the doctor, but also the patient can take, of course, the telephone and ask for an outpatient clinic visit. What's important is if you do those self-management, if you implement that self-management in your daily clinical practice, it is important to have a dashboard in which you can see what the status is of your patient at that time point, and the patient can see it as well. And that's an easy way then to communicate with your patient what is wrong or what is going well. So, for instance, in such a dashboard, you can find things like the quality of life, of the lifestyle, knowledge of the disease, self-management, cardiovascular risk management, disease activity scores. And if a certain aspect of the disease is green, for instance, then you do know there are no problems in that area. So you don't need to focus on that area. If it's red, it means that it's not under control. So, for instance, if the disease activity score is red, you know the patient is not yet, for instance, in remission. You can click on that part and see that the disease activity score has a certain level, and then you have to discuss with your patient whether you should change the treatment or whatever. The other thing, it's not only that you are aware about the status of the complete status of that patient, as well as the patient, but also you can decide about who is responsible for which aspect. So you can decide that, for instance, in our situation, for instance, for cardiovascular risk management, our GPs are responsible for that. So you don't need to do all those different aspects of monitoring the patient with rheumatoid arthritis yourself. You can divide it between different healthcare professionals. So in our situation, the cardiovascular risk management is being dealt with the GP. The nurses, for instance, can be responsible for part of the self-management, and for instance, for the lifestyle. The rheumatologist can be responsible for the comorbidities and for the disease activity score and for the medication, etc. So what I would like to give you as take-home management for the management of patients with arthritis, that according to the definition of health, there is more than disease activity, function, and radiographic damage in patients with musculoskeletal diseases. You have to listen carefully to your patient and to listen to your patient actively, so that you really do understand what does that patient mean? What is the message of that patient? Is there a good connection between the verbal and the non-verbal reaction of the patient in your consultation? The management of patients with musculoskeletal diseases is a team approach. You can't do it on your own. And the patient is member of the team. So the patient needs to know and have information about the dashboard, for instance, as well. And in fact, in our situation, in the web-based system, the patient can see exactly the same information as we as health professionals can see. And they can learn about the different aspects they have to follow. So for instance, previously, a patient was telling you, if you were asking a patient, what kind of medication are you using? The patient was telling you, okay, I have a white tablet, and I have a yellow one, and red and white, and So you didn't know what. And by having this system, we are trying to educate the patient that they should know the name of the drug and they should know the reason why they are using that medication. Because that's important. And I don't know, I think it's the same here in Greece as in the Netherlands. Often the medication is being changed by the pharmacist. So it's the same medication, but from a different how do you call it, pharmaceutical industry. So the color will change or the tablet will change. And then the patient will be confused because they say, okay, I had a white one first and now I have a blue one. What's going on? While if the patient knows that the generic name of the drug is the same, they will be reassured that it is the same medication. So it can help them as well. The patient is the member of the team, so self-management is important, but it doesn't come for free. You have seen that we did some to try to include patients in the self-management program, and only 5–6% of our patients were starting in the self-management program. So we have to educate them. We have to make special outpatient clinics to stimulate patients to be in that, to try to do their self-management. And now we are increasing that number of patients, and we hopefully end up next year probably at 30% of the patients are doing self-management. And for that self-management, education is important. And it's not only educating the patient, it's also educating the health care professional. Because we are taught in a paternalistic way, and we have to change our attitudes. We have to release the patient more or less. We have to coach the patient. So there is some distance between the patient and the doctor. They are deciding together with us what is the best approach for them. And that also makes a difference for us health professionals in this new system. So we are more coaching and more teaching our patients instead of telling them you should do this or that. Tools are important, and especially a dashboard is important, that you have a nice way that you can see right away what is going on with your patient. And try to keep it as simple as possible, that dashboard, but also all the different things that you are measuring in your patient. If you make it too complicated, if you have questionnaires which are too long, the patients will get fed up after some time. So you have to try to make it as simple as possible, the whole procedure. I think this was the end of my talk. Thank you very much for your attention.
Any questions? So you can step down. Και συνεχίζουμε αμέσως με τον κύριο Ριγόπουλο, με το συμπόσιο περί της διαχείρισης της ψωριασικής αρθρίτιδας και ψωρίασης.